All right. So today's program is going to be broken into kind of three different spots or pieces. The first one, we're going to kind of go over what Unity is, some background, some data, how we figured out what the patient population looks like, who may or may not qualify to go to Unity, things like that. We'll go over the protocol, which everybody that has been to in-service has now seen. The distribution scheme, and by that I mean how we determine what patients we take to Unity basically based on a geographical location. There's some idiosyncrasies with Kaiser that are thrown in on this. A quick review of physical and chemical restraint because that's actually required by law. A brief overview of olanzapine. When we first started this endeavor a couple months ago, it was actually before protocol and service had started, so not everybody had seen or was familiar with olanzapine. So that one will be a pretty quick breeze through there. And then the ORSs that actually pertain to peace officers and mental health professionals that allow them the authority to place holds and then transfer those holds to us. So without further ado, quickly, my 8-year-old daughter, I don't know if you guys have seen her, a little blonde head, towhead kid, runs around every once in a while. When I was putting all this stuff together, she really wanted to desperately help me out and be a part of the programming for this. And so she has this game, it's called Would You Rather. And basically it's a stack of cards, you pull one out, it says Would You Rather, and it gives you one option. And then you pull out the next card and that gives you the second option. So I told her, why don't you grab a stack of those, we'll throw them in here periodically. So the first one, would you always have to stuff your pants with hermit crabs before leaving the house? Or, have surgically implanted antlers. By the way, potty humor is huge in the 3rd grade, just in case you guys have little kids. You'll learn that. So, anybody? What would you rather do? Antlers. One person opted for the crabs. And I mean hermit crabs. So let me just be clear on that. So, and that was Marcus Stanton. So anybody want to give him grief for that? It's fine. Okay, so what? Yeah, not surprising at all. So what is Unity? It's a 16,000 square foot psych emergency services facility that has all these things here that you can see. It has an open observation area. It has calming and seclusion rooms. On the upper floors, there's 102 inpatient beds, and it will be staffed by needs 24/7. So a quick clarification on some terms. You're going to hear Unity, you're going to hear psych emergency services, and you're going to hear PES. They're kind of all interchangeable. Unity is the global project that includes the inpatient services, it includes the psych emergency services, it includes some wraparound availability for clients that arrive there. What our interface is going to be the psych emergency services, or PES or PES. So if I say PES, I'm talking about where we drop patients off. And if I say Unity, I'm still referring to the PES. They just kind of were interchangeable terms for a while. It's a consortium between Adventist, Legacy, OHSU, and Kaiser. Kaiser is kind of a half-in, half-out player. You'll see that in a little bit based on the distribution scheme on how we take patients to Unity versus other facilities. The only one that is not participating is Providence. For whatever reason, they felt that they could go it alone and like the way they provided their services already, which throws a bit of a wrinkle into things for us, because if a patient is a Providence patient or wants to go to Providence, Unity is not really an option for us, so we have to go to Providence. We'll see that again later here. So this is the construction schematic of Unity. This line here, up to this black line here, this is all existing building. All of this is existing. And for some of you that were here a little bit earlier, you heard Rick Ralston talking about permitting. What he was talking about is this little entrance and ambulance entrance here doesn't exist at this moment. And the reason that it doesn't exist is because the Moda Center sits right about here, and everything underneath here are two 36-inch sewer lines, a whole bunch of communication equipment, and telecommunication stuff for the Moda Center that they wanted Unity to fix or to make sure that there's no damage to that before breaking ground for this extension to the building. However, the wrinkle was they needed to have a permit to do that, but the city wouldn't grant the permit until they did that work. So they're kind of going back and forth of, well, we need the permit, and they're like, well, no, you have to do this stuff first. So the short of it is, this will probably exist around July or August. In the meantime, there will be an ambulance entrance for us to back into where we will drop our patients off. It'll be a Sallyport style entrance where we'll be met by either a physician or a nurse practitioner. They'll do their quick intake, and that's when we're going to transfer care. So, what's that? In the Sallyport. You'll go into the Sallyport to do it.
And that could rule out inappropriate medical?
Yeah. Okay. Yeah. So they'll do a secondary medical screening after we've done our stuff too. So a bigger picture of the area. This is going to be the open milieu that I talked about, where there's going to be recliners, there's going to be TVs, they're going to have some arts and crafts. And it's going to be really focused on calming the patients down, not having that constant agitation of beeping monitors in an ED, the frenetic pace of nurses and doctors moving from room to room, patients that are sick and screaming for other stuff. A lot of these patients that will be eligible to go to Unity, really what they need is they need a less stressful environment where they can really kind of work out what their issues are. All right, some background and data. So as you guys all know, the population of the city is just exploding. And with that, people are coming in with their pre-existing conditions. Our population already had pre-existing conditions. So our mental health needs are increasing. Portland Police also has gotten out of the habit of transporting patients on mental health holds or psych patients that they believe need to be evaluated. So they're calling us for that. So as of, I believe, 2 years ago, our BE8 specifically volume has spiked almost 100%. So really what is happening is they were having a lot of overcrowding already on the psych floors. So that's pushing patients down into the ED, just even on the walk-in level. And since those patients needed to be admitted, no rooms upstairs, they're boarded in the ED for a few days at a time. We bring in a couple more, they're boarded, and then there's just backup for regular ED patients. So you guys have extended wait times, patients have extended wait times, and we needed to figure out something to do. So what the thought process was, and based on a couple other models, was let's see if we can pull out the folks that don't have an underlying medical or traumatic issue, and they're just a behavioral health concern. Their psychosis is acting up. They are bipolar and they stop taking their medications. They have suicidality only without an attempt. They have depression that they can't get under control. Things of that nature that really they need psychiatric support. They don't need medical support. Let's take them someplace else. Let's remove them from this environment that's agitating them even further, and let's put them into a space that is maybe better suited for them. So that is what's driving a lot of this, because there's just no room. What do we do with all these folks? You can kind of see in this graph a little bit. It's 2014 in blue, 2016 in green. January of 14, we ran 138 behavioral health, or BE8 calls, excuse me. Same time, 2016, we ran 308. So if you do the math, that's like a 99% increase in behavioral health calls, just BE8s alone. And that trend continues across the time span. It ends here in November, because when I started this, that's as far as we were. But thanks to the snow, we're here in January. So we use the AMR database to categorize behavioral health calls by destination and by week of year. One thing that really struck out was that we had a lot of transports of behavioral health calls to Adventist. And then all of a sudden, that dispersed throughout the county. And when we looked at it, it was right at the same time that Portland Police said, we're not going to transport anymore, we're calling you guys. So they were driving us by saying, this person's on a hold, they have to go to Adventist. Or this person's in my custody, we have to go over here. Once they stopped doing that, they're like, you guys go wherever you want. So Adventist was still a major player, but the distribution basically spanned the entire county. So we also looked at age and gender, primary dispatch. What are we being called for? Is it always a BE call, or is it respiratory? Is it diabetic emergency. There was a few car wrecks in here that it actually turned out the person was having a panic attack and bumped into a parked car, but we were dispatched on a TA3 or TA1, I don't recall which. And we looked at the impression, so that's what you guys thought was going on. Not necessarily what their chief complaint was, but after you did your assessment and vital signs and all those other things, what you determined was their primary impression. We also looked at secondary impression as well. Volume by hour of day, whether they were restrained, and were they physically restrained, chemically restrained, or did they get both? So we looked at those, and then some inclusion versus exclusion criteria. And the inclusion and exclusion we'll touch on a little bit more, but basically I was trying to figure out, of all of these behavioral health patients with that impression that we ran, how many did we think were sick and needed to go to an ED versus, theoretically at that point being able to go to Unity. So here's the age and gender. I don't think there's any shocks here, with men being slightly more psychotic than women, but really by less than 1%. So age we broke into 3 groups, and that's 18 to 35, 36 to 54, and then 55 plus. Not a lot of geri psych on our end. Jesse? Correct. So by protocol, 18 to 64. So younger than 18 goes to the medical ED, older than 64 goes to the medical ED. Pete?
Were you able to tease out not to do psychosis and
Not 100%, no. That would have probably required a lot of chart reading, and my sample size was 4,684. So I didn't want to read all those narratives.
Psychosis regardless of nature.
Right.
Okay.
The number was actually a lot larger than that. And this time frame that we picked, these 4,600 people, was from January 1 to middle of July 16. And we actually had 8,000 hits. But then when we scrubbed for age, that's when we ended up with 4,600. So in just over 6 months out of 2016, you guys transported over 8,000 people that you thought had a primary or secondary impression of behavioral health. So these are some of the different dispatch types that we got. Obviously the BE8 is the big winner with nearly 30% of our call volume on this. But then as you can see, it was BR1s, we had some OD3s, we had a seizure, whether that was a legit seizure or a pseudo seizure or attention seeking. Again, I can't speculate, but it just goes to show that we're encountering these people on almost every type of dispatch. And here's the primary impression by group. So under behavioral psych, there's a subset of choices that you could pick. We just kind of grouped them all together as behavioral psych. So again, not a big shock that that is the largest impression group type with 73%. And then you can see how it breaks down from there. With diabetes, there were 7 calls that somebody complained of diabetes, and that you thought that was part of their issue, but they also had a behavioral health issue in conjunction. So volume by hour of day. For whatever reason, I thought we would be running a lot more of these patients in the wee hours of the morning. But when somebody pointed it out to me, I was like, well, that really makes sense that between 1, 2, 3, 4, and 5, everybody's asleep. But then they start waking up around noon.
Or kicked out of
right,
shelters, night shelters.
right. But they're not moving about. They're not up. They're not having issues. And then right about noon, maybe they're starting to wake up. Maybe they've had a full 8 hours of overstimulation from the environment that they're in. They've been able to start using methamphetamines again. Who knows? But right around 1 o'clock in the afternoon, that's when people start to have issues. So Unite folks, you're kind of off the hook. The rest of you day swing types, this is when you guys see all of them. So physical and chemical restraint. So of the 4,600 patients, only 368 or 8% were physically restrained. I thought that was a really impressive number. So you're taking and you're encountering these people that are having whatever kind of mental health disturbance. They're agitated, they may be angry, they may be acting out, and whatever techniques that you guys use to help calm them down are working. You're getting them to sit down on the stretcher. You're getting them to be compliant with what you want to do without having to resort to physical restraints. So to continue that, only 273, or just about 6%, were chemically restrained only. So again, not a lot of need for chemical restraint on these folks of the group type that I pulled out. And between all of these, I believe it was only like 186 received both. So a very small percentage of people got both physical and chemical restraint. So the inclusion versus exclusion, again, without reading 4,600 narratives, what I looked at was, did they get an IV indicating maybe you thought they were a little bit sicker and were going to need either some fluids or a medication of some type? Did they get a 12 lead because they were complaining of chest pain and you were going beyond just the further cardiac monitoring where somebody has an elevated heart rate, so you throw them on the monitor, let's see what we have, but did you take it a step further and say, this doesn't seem quite right, I'm going to run a 12 lead because I think something else is going on. So I included that as well. Or did they receive some type of medication? Because as you guys know, and we'll hear about here in a minute, if they get anything other than olanzapine, that excludes them from Unity. So did they get a medication? That would exclude them from the PEZ. And by and large, of this subset, 70% of the people didn't get any of those things. So it seems like of all the people with a primary or secondary impression of behavioral health, 70% were eligible to go to Unity. Okay, so another quick would you rather. Would you rather have a second smaller head attached to the top of your current head or fall face first into a pile of dog poo? There's that potty humor. All right, so here's the protocol. So again, everybody's been to in-service. Dr. Ju covered this a little bit there. Same thing. It's a voluntary patient or a patient on a police or a director's hold, which we'll talk about. It's a primary 911 call or a police request. So somebody calls for themselves or the police calls for the BE8. There's the age, 18 to 65. I said 64 earlier, it's 65. They have any of these mental health complaints. They're alert and oriented. They have no trauma or other medical condition. They can have some minor abrasions like the schizophrenic that's crawling through the blackberry bushes and comes out. The person that makes the weak suicide attempt by dragging the safety razor or paper clip across their arm, they're okay to go. But anybody that's going to require any kind of wound care or suturing, they're not equipped to handle that, so they're going to have to go to the medical AD first. They can ambulate and breathe, bathe, toilet, they can breathe too, that's always important. Eat, drink, and as Dr. Ju always says, walk, talk, and eat a sandwich. So Sean has allowed me to go out and purchase a whole bunch of gas station sushi to put into the coolers. So when you find these people, if they can take down the spicy tuna roll, they're good to go. If you can get a blood glucose between 60 and 300, and the vital signs within those parameters, as you can see. If you can get it, yes.
Why such a low threshold on heart rate?
Yeah, that's pretty weak.
So,
I mean, if the respirations are at 25, that shows a state of anxiety.
Right.
You're very, very anxious, and
you're going to have an increase.
Easily.
Right, yeah, we're going to talk about that a little bit too. But they want to make sure that people are kind of within normal parameters for heart rate. The respiratory rate is a little high on the top end, but what they want to make sure is that people aren't either withdrawing from drugs or alcohol. They're not currently meth intoxicated, other things that they can't handle. So if somebody has a good solid heart rate that's not tachycardic or worrisome, they're good with that. Yes, people that are agitated are going to have increased blood pressures, they are going to have increased respiratory rates, and they are going to have increased heart rates. But if that's how you encounter them, and you get them to calm down, you give them an olanzapine, and you get them out of the situation, the environment that they're in, have them sit in the back of the ambulance, and their vital signs start to creep down towards normal, that's okay. Then they can go to Unity. So it's not your first set, it's your most recent current set of vital signs. Pete, did you have a question? Allison brought up a good point. So they're being intentionally conservative at the start because they want to validate this program, make sure that it works, and that they don't get overwhelmed or find themselves in a situation of having somebody that they can't handle. Over time, as staff grows in experience, as we grow more comfortable with the program and the process, these things may change a little bit. But again, this is not a medical facility. This is a psychiatric facility. So people that have any kind of impairment of vital signs that could lead you to believe that there's an underlying medical issue, that's not appropriate for this facility because they can't handle that. So some exclusion criteria is drug, overdose, or intoxication. So the chronic alcoholic that's had their par level of drink for the day, that would be okay if they can perform those activities of daily living. So the walking, talking, eating a sandwich, as Dr. Zhu illustrated, the guy in the three-piece suit and carrying the briefcase, always a good candidate. But if they're stuporous, if they are urinary incontinent because they just are too drunk to get up and go to the bathroom, again, they're in an open milieu. There are people there that can interact with them that are staff. However, it's not a direct one-on-one kind of observation.
So admitted drug use is okay as long as their vitals are with it and they can be a
Yeah. Yep. So any medical or traumatic conditions, as you can see with altered level of consciousness, abdominal pain, etc. Any derangement of vital sign, anybody that requires chemical restraint except for olanzapine. If you give them the olanzapine, that's fine, but if you have to give them Versed, Geodon, anything else, that automatically takes them out of unity. Signs and symptoms of acute drug or alcohol withdrawal. So the tachycardia, hypertension, tremor, and hallucinations. So some red flags to think about: the waxing and waning level of consciousness. Generally, people with behavioral health issues don't have that. That's more of a delirium type thing. So if they are up 1 minute, down the next, back up again, that would suggest more of a drug or alcohol issue, and that's not appropriate for unity. So if they have that waxing, waning level of consciousness, red flag, think medical. Dementia patients have that normal level of alertness. They're just confused. They are agitated, don't know where they're going. And then delirium has that waxing and waning. So abnormal vital signs, dilated or pinpoint pupils, again, suggesting drugs or alcohol. Any kind of disorientation. So your dementia and Alzheimer's patients, those are medical patients exclusively. You're not going to see probably many 65-year-old Alzheimer's patients, and that's the age cutoff. So the 75-year-old that's agitated with dementia, they go to the ED anyway, so they wouldn't even go to Unity. If they have that first psychotic episode over 30, generally speaking, that is a rarity. Not to say that it never happens. In probably the second class that we did, somebody related a case that they just were on where a woman, 33, had her first psychotic break, and it was a legit psychotic episode. So just because they are 31 and they're displaying signs and symptoms of a behavioral health emergency doesn't automatically mean they're not, but chances of them having their first psychotic episode after the age of 30 are greatly reduced. So very acute onset over hours and days. Generally, behavioral health is a slower onset. So any signs and symptoms of your mood disorders, your thought disorders, hallucinations that are primarily auditory, paranoid ideation, delusions, pressured speech, just the flight of idea, those types of things. So don't always assume that people are psych if they have some of these impairments, because there are medical problems that can manifest as the same. So just the quick pearls. Remember the orientation. Generally, the waxing and waning level of consciousness is more of a delirium rather than a behavioral health issue. Pupil size can indicate whether it's drug or alcohol related. Level of consciousness. Dementia is slowly progressive over time. Psychosis over age of 30. Auditory hallucinations are schizophrenic. Visual and tactile are more drug-related, and is noted there in the bottom. So, okay, distribution scheme. So basically how this is going to roll out is, and Pete actually said he's had requests to go to Unity already. So they've been putting this out to the behavioral health community for quite some time to hopefully educate some of these clients that we're going to run into to ask or request to go to Unity. The primary driver of destination is going to be patient preference. So as always, when we're on scene and you determine that they fit all the inclusion criteria, don't have any of the exclusion criteria, and it's getting time to transport, and you say, where do you want to go? If they say Unity, great, head on over. If they say I want to go to Adventist, you can say, okay, we're good with Adventist. However, remember, there's this thing called Unity. You may have heard of it, and based on what you're displaying, what you're telling me, and the programs that they can offer you, that may be a better fit. But if you still want to go to Adventist, no problem, we can go there. So patient preference is the primary driver. Now, if they aren't able to choose or they don't really have a preference, pick what would be the appropriate hospital. So in these cases, it's probably going to be Unity. But if they're a Providence patient, you're kind of in that Providence area, and they say, well, usually I go over to Portland Providence to get psychiatric care, just go to Providence. Pretty much every place else, you're going to go to Unity. So Kaiser, like I said, throws the wrinkle into things. They are a half in, half out. Basically, if you are in East County, kind of east of 205, Gresham, maybe that one mutual aid call that you run in Clackamas per rotation.
Per hour per day.
Yeah, right. Kaiser Sunnyside is the choice if they are a Kaiser member. If you're kind of in the core, Inner East Side, maybe downtown, Unity, it's basically the closest facility that you are in relation to. And if you're out in the West Hills, or now weirdly doing a Washington County mutual aid call, you can go to Kaiser West Side.
I'm sure they pulled all the ED staff to come up with these numbers as to where they want their psych patients.
Yeah, I'm sure. So, okay, another quick would you rather. Anybody have any questions on the distribution scheme? I know I'm kind of buzzing through stuff, but anybody? No questions? Okay. So would you rather post between 5:05 and 5:20 without stopping for an hour, or post at 9:32 for 6 hours without moving, and there's no Wi-Fi? Okay, let's take a quick 10-minute break.